Welcome, everyone, to today's IMWG Conference Series, which will be an overview of the IMWG Summit, which was just recently held live in person in Vienna, Austria. Joining me today, very pleased that María Mateos from Salamanca in Spain is able to be with us today. So welcome, María. And Vincent Rajkumar from the Mayo Clinic in Rochester. So welcome to both of them, who will be able to comment on the presentations. We're very grateful to Janssen and Takeda for specifically sponsoring this conference series presentation today. So the 13th annual IMWG Summit was held June 7th to 9th in Vienna, Austria, and we covered key questions for the next 5 years. We tried to be more forward-looking. And so I think, and you guys can perhaps comment on this, everyone was so excited that we were back in person. I think that maybe you could both even comment on that. It was wonderful to see all of our colleagues, many of whom we hadn't seen for over 2 years, and just great to have a chance to connect. And it makes a big difference versus Zoom. So María, what was your reaction to that?
Yeah, no, exactly what you said. And it was great to see in person people since more than 2 years ago. But well, on the other side, it's true that the Zoom meeting is also feasible, is also possible, as we are doing here today, right now. So, but it was great.
Yeah, Vincent?
Yeah, same here. I really was glad to be back and to meet all our friends again, and made for some really good interactions as well. So yeah.
Right. So just to highlight that during the summit, there is an awards dinner which was held on the Wednesday evening, and it was wonderful that we were able to, in person, give out the awards and have a special event in person. And a special part of the award ceremony is the IMF band with star members Vincent and María. You can see here Vincent playing the guitar and María as one of our star singers, singing special words to the music of Hotel California. And I think that several people have some video of that, which those interested might want to track down. But the main thing was for the group to get together at the orangerie at the Schönbrunn Palace, and you can see the large group connected there. And for dinner inside, but obviously the main thing was for the award, which is given out in my name, the Achievement Award. This year, the award went to Bruno Paiva from Pamplona, and with his mentor and close friend, Jesus San Miguel. Just wonderful to have this award go to such a dedicated and wonderful researcher. And then with his family and colleagues, including María in this picture, just great for the whole Spanish team to get together and celebrate the achievements of Bruno within the Spanish team. And then it was great to have Hervé Abbott-Lassault from France. The IFM team received the Robert A. Kyle Lifetime Achievement Award. Again, great to see him with his colleagues and his friends. And then also with previous awardees of the Kyle Award. Just a great opportunity to celebrate in person. And so the mission of the IMWG is to both conduct collaborative basic clinical and translational research, and also to produce consensus guidelines for the myeloma. So those two goals, to be able to conduct ongoing research, but also to provide guidelines for the myeloma community. The chairpersons overseeing the development of the program and implementing the program are here, including myself and Vincent. And I do believe that we had an innovative program focused on shorter presentations with more time for in-depth discussion, which I think we did achieve. The overall sponsors for the summit, you can see here, we are very, very grateful to all of these sponsors, and that has been consistent even all over the last 2 years when we had Zoom activities. So very, very grateful to all of our sponsors. And so the plenary sessions this year were, as listed here, early disease, minimal residual disease, frontline therapy, early relapse, and late relapse. And so what I'm going to do is to touch on each of those plenary sessions, show you a couple of slides, and then have input and reaction from our two guests today. So I chaired this first session on early disease, and it was a pleasure to have the initial presentation from Sigurdur Kristensen from the University of Iceland, who leads the iStop effort. Iceland screens, treats, or prevents multiple myeloma. And the initial results from the screening of over 80,000 Iceland residents are coming in, and there is a RCT randomized control trial which allocates patients identified as having MGUS or an M component into 3 groups. One with no further follow-up, one with standard follow-up, and one with intensive follow-up, which would be over on the right, arm 3. And the very striking thing was the number of cases picked up in arms 2 and arm 3 of over 3,000 individuals identified, particularly some patients with active myeloma, and very interestingly, many more cases in the olive green. The olive green in the 2 right bands with the 92 and the 133 identified is smoldering myeloma. And so if you exclude indolent disease, individuals who might require intervention, the differences remained. And the important observation, initial observation at this time before the randomized trial is completed, is that smoldering myeloma is more common than we had realized, and actually has a prevalence of about 0.5%, half a percentage point in those over the age of 50, and more common in men, which is the blue, versus the pink, which is women. And so the first question which we can touch on is, should we screen for MGUS? Certainly does identify a higher number of individuals with both myeloma or smoldering myeloma. And then earlier intervention is achievable. But although these findings are encouraging, the overall survival and the quality of life in the 3 arms remains to be fully evaluated in the next 1 to 2 years, when maybe then there will be a statistical difference between the 3 arms. And so the first question, Mary V, is if we look to the next 5 years, do you see screening as becoming the way forward, or how do you view screening at this point?
Well, I can't say today that screening is recommended for the general population, basically because Sigurdur Kristensen clearly pointed out how maybe not yet. We have to wait in order to see how the iStop multiple myeloma study will evolve, especially in terms of overall survival, and also, and I think that this is very important, quality of life. We have to realize that we are going to do a diagnosis of a disease to the patients, and sometimes for the physician who is visiting the patient, it is very clear that MGUS or smoldering at low risk is maybe an indolent disease. But this, well, we have to put in context the psychological impact in the patient. So I would say that not yet. On the other side, much more routine analyses are being done in the normal population. And of course, if whatever physician detects proteins elevated and M component is detected, my recommendation, of course, is to move forward with the recommended workout in order to do the correct diagnosis and to plan an appropriate management, follow-up, clinical trials, and so on.
Right. Yeah, we do definitely do need to wait. I mean, obviously, the transition from MGUS to active myeloma is only at 1% per year. But one of the things that is being observed is that there are other things which are potentially linked to MGUS that could contribute to decreased or lesser outcomes. But these details need to be evaluated to see what those are and what the implications are. So a little too soon to make a decision on screening. And Vincent seems to have dropped off for the moment. Are you there, Vincent?
Yes, I am.
Oh, okay. Your picture dropped off. Any additional thoughts on this?
No, I agree with María that, we don't have data right now to recommend screening for the general population. If screening is indeed valuable, then we will see it in survival differences. Right.
So we're just waiting for another year or two, probably
years,
on
maybe.
that. Yes.
Yep.
Okay, so a next very interesting presentation came from Bruno, who was looking at testing for high-risk smoldering. Obviously, the three of us on this webinar today have spent a lot of time looking at what are identifiers of high-risk smoldering myeloma, what are the factors that would allow us to predict disease progression. And so Bruno presented some information and emphasized a couple of points. One is that it's obviously extremely important to identify the subset of patients with no risk of transfer or very, very low risk of transformation. So those patients can be excluded from any type of interventional activities. And so then the second thing that he emphasized, which has been a big emphasis within the Spanish teams, both in Salamanca, I think, as well as Pamplona, is CTCs. Basically, this means clonal tumor cells, which is basically clonal plasma cells, or basically myeloma cells in the blood. The detection of myeloma cells in the blood can replace the detection or quantitation of bone marrow plasma cells and in the different risk models. And so he showed, for example, on this slide here on the left, using very, very sensitive techniques. It seems like a very, very small number, but with a cutoff of 0.015%, you can have a cutoff indicating the likelihood of progression or not. And so this is a new tool which does seem as if it can be quite powerful. And so, first of all, again, María, do you agree that this really can be a tool that can be helpful moving forward? It's obviously a blood test, which is great.
Definitely. I think that this model evaluating the circulating tumor cells is going to complement the current models. And I think that we are building and we are generating a lot of markers predicting risk of progression to multiple myeloma. And I think that this is good for the patients, because at the end of the day, we will be able to accurate much more the risk of progression to myeloma in every patient. So, and as soon as we generate techniques available worldwide and even not painful for the patients, like the peripheral blood, I think that this is much more better. But patients have to understand that there are different ways in order to evaluate the risk of progression to multiple myeloma. And what we are doing right now is to improving the accuracy for the identification of the risk.
Right. So obviously we've been using this 2-20-20 model based on the M component, the free light ratio, and the bone marrow plasma cells, which has been good, but room for improvement. So Vincent, any reaction or blood clonal cells being evaluated at the Mayo Clinic by the myeloma team there?
Yeah, we do routinely. And what María said is the right thing, which is these things will augment or supplement the other models that we have developed.
Absolutely.
And so if you do the IMWG score, right now it has FISH on top of the 2-20-20.
Right.
Then when you add the circulating plasma cells, you will get additional prediction. But the key is to remember that we don't need to identify, all of them don't need to identify the same patients. That's a misconception. All we need to do is to use some combination, whatever is available, to identify the people who have a 50-50 chance of progressing in 2 years. That's our goal. Sometimes we may be able to identify even higher risk of progression and give them more sense, but the fact that they identified different people is okay, and it's actually good for us. And I hope that this is something that is more widely available.
Exactly. It's very promising and needs to be standardized and widely available, which we'll touch on in just a moment, actually. Okay, so moving forward, obviously, María, you presented if you do have high-risk smoldering myeloma and are comfortable with that, what should be done about it? And you presented, again, the outcomes from your GEM Caesar trial, and I just show one set of graphs here. I think that it's very important how many patients over time have ultimately developed symptomatic disease. How many have actually lost their MRD status, but have not yet developed any symptomatic disease. But overall, it's obvious from the left-hand graph is that overall, patients have done very, very well with this intensive treatment, the KRD plus autologous stem cell transplant. So what's your interpretation of the outcomes so far? Are they kind of what you expected, or what is your reaction to the results of your study?
Well, in terms of time to progression to symptomatic disease, I think that the curve is very good, and the follow-up right now is 55 months. But you have to know that the primary endpoint was minimal residual disease negative sustained over time, and the gene Caesar implied treatment for 3 years. And our idea, and this is the most intriguing question for me, is to evaluate how many patients 5 years after autologous stem cell transplantation will be in sustained minimal residual disease negative, because this could be a potential surrogate marker for cure. And honestly, we are utilizing here minimal residual disease negative with a sensitivity level of 10⁻⁶. And this is the reason why we are observing how some patients are losing the MRD negative when they finalize the treatment. And this, is putting in context that maybe high-risk smoldering is closer to myeloma, but definitely we will see how many patients will reach this situation, and we will see what happens. But in principle, the trial, from my point of view, is quite positive. And as always, we are learning a lot of information.
Right, exactly. And obviously, we have the US trial led by Rajkumar, and the full results of that have not been presented, hopefully at ASH this year, but a very, very similar study where daratumumab is added to the KRD with a similar endpoint of achieving MRD at 1, 3, and 5 years, and obviously looking at progression-free survival. But we also discussed the results of the study from the ECOG with Sagar Lonial, which looked at using just lenalidomide versus observation, indicating with the blue line here, you can see that the patients receiving lenalidomide had a superior progression-free survival. So the question was really what's next, and I think María, you said very honestly we don't know what's the best, and I would just turn it over to Vincent now, who was really emphasizing the difficulty in deciding what is next, because we have good results with the aggressive approach from the Caesar and probably the Ascent, where we're expecting maybe even higher levels of MRD negative. But also in the short term, we have quite good results with very simple therapy like lenalidomide alone. And Vincent, maybe you can expand on your comment, which is that really it's going to take us a long time to look at overall survival and understand truly what are the differences in some of the studies. There are randomized trials going on looking at RD versus VRD, things like that. So how do you see the data evolving in this space? How will we understand what is the best thing to do?
Yeah, I think, a lot of the confusion comes by people who are not very clear on what we seek to achieve and not very clear on what we know and what we don't know. What we know for a fact is that if you have 100 patients with smoldering myeloma, about 35 have the high-risk smoldering myeloma. We are only talking about those people. The remaining 65, we are comfortable with either observation or enrolling in some clinical trial. Now, these 35 people who have high-risk smoldering myeloma, we know that len or lendex for about 2 years will reduce the risk of progression to end organ damage by 90%. We know that they have better overall survival from one of the two trials, which has mature follow-up. So at this point, that's what we know. What we don't know is, will they do better if you add 2 or 3 more drugs and treat them more like myeloma? And that's the subject of current randomized trials. There's the RD versus DRD going on. So until the results of that trial comes, I'm comfortable recommending len or lendex for the high-risk smolderers. Or if there is a good clinical trial like Caesar or Ascent or something else, enrolling them on that. And that's my judgment call. Now, there might be some patients where you feel like, they've had this high-risk features for almost 4 or 5 years, and this is the first time I'm seeing them. So you could possibly watch them. But by and large, if I de novo see a new patient, I'm pretty clear that intervening with len or lendex will reduce the risk of end organ damage. And that's what I would recommend. It's not indefinite therapy, it's 2 years. But more preferably, enroll them in a clinical trial like Caesar or Ascent or one of those other things.
Right. And so, just to highlight that, what María has on her slide here is something that is going to be happening, I think, where, and we'll come to this later in our session today, we've had such exciting data with some of the newer therapies like CAR T-cell therapy and the bispecifics, producing excellent results in patients with relapsed refractory disease. How about considering those in the high-risk smoldering setting? And I do believe that some pilot studies with those will move forward in the coming year. And so that's going to be interesting. Fortunately, we do have CAR T and bispecific therapy, which is reasonably well tolerated with not too high a level of CRS. So it is the kind of option that can be considered. But anyway, we need to move forward. But it was interesting that this is an area where it's going to take time to understand what is the best strategy for sure. So moving ahead, minimal residual disease has obviously been a key topic for the last several years, and MRD negative is a key endpoint in clinical trials, for which we're seeking surrogacy status from the FDA. We're asking the FDA to accept it as an endpoint that can be used to compare outcomes in clinical trials. But there are a number of issues that need to be considered, and one of them is standardizing MRD testing. Alberto Orfeo showed us that results with NGF, flow versus sequencing NGF, negativity at the 10 to the minus 5, 10 to the minus 6 show equal benefit prognostically for patients. Then Alberto showed us where do we stand with the authorization of these assays. Now, the NGS test has actually been approved by the FDA. One very, very important recent development is that the next generation flow product, the one on the right, NGF product, has recently been approved on the European side with what's called IVDD, which means that this cocktail of antibodies in a kit has been approved and is available on the European side. And this will be very, very helpful. Related to both availability and also the cost. It's estimated that the cost is in the range of 133, I guess that's dollars, versus 950 for NGS. So this is an important development, which is because the company Becton Dickinson took over the Spanish company. Alberto emphasized one other thing, which is that with the flow, in addition to having a cheap and possibly now an approved test, you can simultaneously look at MRD, CAR T cells, which are circulating in the blood, plus you can also monitor the immune status of the patient. And so next generation flow does have a number of advantages. And so I know, María, you're very much involved with this, but maybe Vincent, so you're not so much directly involved in the flow technology and the results. How do you view the value of the next generation flow?
So, Brian, as we did in the MRD consensus guideline paper, really what we're looking for is deep minimal residual disease negative. And whichever technique is available, that's okay, as long as you get the deep level. And it looks like both techniques can get to a very low level of detection. Both techniques miss some people and pick up some. So I don't think that I'm wedded to one technique per se, whichever is available. Yep. We actually use the flow more commonly in Rochester, for example, but even in Mayo Clinic, Arizona, they use the sequencing more. So it's what's available, and it might vary across countries and places. So I think the flow has the advantage, like you said, of in one single test, you can also assess other components of the bone marrow and blood, which is something that we have to keep in mind.
Right. So obviously in Spain, a strong focus on the flow methodology. Although I know that you also do NGS on many samples as well.
Yeah, sure. In clinical research, we do both in order to compare, but in clinical practice, we do flow, and especially we have the results immediately in 24 hours. We evaluate immediately if the quality of the sample is good or not. And in addition, now it is possible to evaluate the CAR T cells and the immune system and all cellularity. So this test is giving us a lot of information. On the other side, it's true that it requires from some expertise in the evaluation, but it is possible to do this test in centralized labs. So it is not necessary every small hospital has to have access to all this technology, and it is possible to centralize in some 2 or 3 centers in each country.
Right. I don't want to go into it in great detail, but it was somewhat distressing that Alberto pointed out that thus far, that broader standardization has not happened. It is a little bit disconcerting, and I think that for patients to be aware is that this methodology is not fully well standardized yet in terms of everything from collecting the sample, transporting the sample, and then processing and running the samples. And so at the patient level, we need to have a degree of caution in interpreting these results, just because some extra standardization is still required.
Yeah.
Okay. Hervé Abbott-Lasso made some strong points about if you have MRD testing, what is the value of having a negative test? And obviously, he just emphasized once again, if you have a negative test, this patient, like the top blue curve here, is going to stay in remission longer. And so the PFS, or the remission free survival, the progression-free survival is better. He showed something which was a little controversial, and maybe you guys can comment on this, is that he showed that in the Cassiopeia trial, which is the French DARA VTD trial, that for patients who had poor cytogenetics, the red and the green, deletion 17 or 414, who did achieve MRD negative, they did not have an improved outcome. And so he really was very negative about this particular point. And so his conclusions were that obviously having MRD in our trials, very important, 10 to the minus 5 or 10 to the minus 6 if possible. A controversial point was whether we should look at it as a standalone endpoint, or should we also want these patients to be in a traditional complete remission. And then he talked about where maybe it's not so important for patients with high-risk cytogenetics. I don't know who'd like to go first. Maybe Vincent, you could go first. What about this idea that it could be a standalone endpoint separate from CR?
Well, it could be. And the issue is that we have defined MRD, and I don't like to change definitions. Right or wrong, we made the rules. We published a paper in which we defined MRD negative as requiring a CR. What he's talking about is not really MRD. It is basically NGS, or NGF should be performed independent of the CR. Yeah, sure. And you could call it NGS negative or NGF negative, and then see if that alone predicts for outcome and whether that's as good as MRD negative or even better than MRD negative. And if we have such data, then we can go back and see if we need to revise the definition. But to tell regulators like 3 years after we defined MRD that we're going to change the definition of MRD will not look good. And so that's why I feel like what people are talking about is the bone marrow test. And the bone marrow does not capture the whole body. It's one single spot. And the monoclonal protein, however, may be something that could be derived from a spot that is different from where you put the needle in. Right. And so it's something that I would agree if there's data, but I don't think we should change definitions quickly.
Yeah, but we could have a category NGF negative or NGS negative.
Exactly.
So María V, what do you think?
Yeah, I agree. We can't confound to our patients, and patients are used to the physicians to follow the M component. It's quite confusing to say to a patient that he's in PR because the M component is visible, and at the same time to say, let's go to the bone marrow in order to evaluate the minimal residual disease, and we can potentially say the minimal residual disease is negative. This is something contradictory. A patient can't be in MRD negative if you see the M component. And I think that this is important. In clinical research, I agree with Vincent, we can do measurable residual disease after induction, transplant, consolidation, regardless of the serological response. But the patients have to know that it is quite contradictory to see or to be in MRD negative if they don't present at least complete response. And concerning the possibility of a measurable residual disease to overcome or not the cytogenetic information, I think that this should be confirmed because we have some data indicating that the achievement of MRD negative is able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. So I think that the situation is not black and white, and maybe this should be confirmed in other studies.
Right. Thank you. Yeah, I agree. We don't have too much time, but I think that the consensus with regard to the cytogenetics is that it did seem to be the case in the Cassiopeia trial, but the impact may vary from treatment to treatment. So, maybe that was the case in Cassiopeia, but maybe achieving MRD negative with regard to cytogenetics could be different in using a different treatment, perhaps, So would you agree that people felt like this is maybe still an open point? Is that fair?
Yeah, sure. Yeah.
Okay, so Jesus San Miguel talked about how should MRD positive patients be managed, and he talked about some of the difficulties in assessing MRD that I was touching on. That the quality of the bone marrow samples, patchy infiltration in the marrow, hemodilution, and the like. And so sometimes it's hard to know if a sample is positive or truly negative. And one thing that maybe we could talk about, which has been something discussed for a long time, and it's true for patients who have a residual M component, as well as patients who appear to have a small amount of residual disease, patients who are MRD positive, maybe with a small amount of MRD positive, but seem to do quite well. And one aspect of that was the identification of an MGUS-like phenotype, which we've known about for maybe 10 years, I guess. But Mary B, maybe you can comment on this. Do you think that we should be looking at this subcategory of patients who maybe can have a favorable outcome based on a better immune profile, perhaps?
Yeah, sure, Anna. The rationale for this is all of us have some patients, they are not in MRD negative, they are not in complete response, they present a small M component, and they are long-term survivors, and they never progress. And we have to try to understand why. And the immune profiling is a key element. And we have to try to identify these patients throughout what you mentioned, the MGUS-like profile. These patients are characterized by the presence of, I would say, a positive immune profiling, able to control the small quantity of the disease these patients present in the bone marrow. And why is it important to identify these patients? Point number one, because these patients will not be over-treated. They don't need additional treatment. And point number two, because the outcome is going to be comparable to those in minimal residual disease negative.
Absolutely. And so there was a lot of discussion about that for that exact reason. We need to identify those patients because they are not appropriate for maybe an aggressive backup therapy for MRD positive patients. We need to look cautiously and maybe exclude these patients that maybe don't warrant an aggressive second type of therapy. So let's go ahead now to the session that was chaired by Vincent. The big question here is, are 4 drugs better than 3, a quadruplet? Obviously, we're used to VRD or VTD or VCD, but adding, for example, daratumumab or isatuximab to that to give us 4 drugs, is that the new standard of care? And Vincent talked about different things we can do to improve it, the issues that we need to think about, including the cost, the toxicity, how do we evaluate if a quadruplet is better than a triplet, the level of evidence, and the like. And so really a very fruitful discussion. But in the backdrop to all of this discussion was the results of the determination trial, which were presented at ASCO and came out just at this exact same time. And this is a trial with the triplet plus or minus early transplant. It's basically early autologous stem cell transplant versus later autologous stem cell transplant with RVD as the central treatment, with or without early autologous stem cell transplant. And so Paul Richardson presented this as a plenary at the ASCO meeting, and everyone was talking about it. And the main thing that they were talking about was the efficacy. And the main thing that people were talking about was that there was definitely a longer first remission with the patients who received the early transplant, 55.6 months versus 41.5 months on this particular slide here, the orange bar versus the blue bar. But if you look at the middle bars, the overall survival, you can see that at the current time, there is no difference in the overall survival between the two arms, and really no major difference in the level of or depth of response. And so this is actually very similar to the results of the previous IFM trial. And as usual, there were many efforts to provide the best explanation for what's going on here. Mary V, what is your interpretation of these data with the longer remission, but no impact on overall survival? And should we be transplanting our patients?
Well, in principle, this study shows that early transplant is better than late transplant because the benefit in progression-free survival is evident, but it's true that overall survival is comparable. So I would introduce here maybe the patient preferences in order to reserve a transplant at the moment of the relapse. Is this applicable to all patients? According to the sub-analysis, all presented patients with high-risk cytogenetic abnormalities benefit from autologous stem cell transplantation. And the subgroup of patients with high-risk cytogenetic, when they didn't receive a transplant, the median PFS was of approximately 1.5 years. So for me, this is important. And the third important message is the incorporation of the minimal residual disease, because although more patients were in MRD negative when they received transplant, if they achieved MRD negative without a transplant, the outcome was comparable. So maybe we are entering into an era in which we are going to individualize the treatment based on all list of things Vincent pointed out in his slide, but maybe risk status and measurable residual disease will be incorporated into the equation, and maybe in the future there will be some patients to which we can say you don't need autologous stem cell transplantation.
Absolutely, absolutely. So obviously, Vincent, there has been detailed and extensive analysis of this study. What would be the high points of your comments here? I've seen you really emphasize that now this is something to talk over between the patient and the doctor in terms of the pros and cons of early transplant. How should we approach this?
You are muted, Vincent.
Uh-oh, maybe Vincent has dropped off.
I think I completely agree with Marie V. This trial shows that transplant works. It gives you a very long PFS, and the timing can be flexible. But people have to keep in mind, not everyone can do a delayed transplant. This is something that is not possible in many countries. And so it's not possible to collect and store stem cells even in the US and many centers. So if it is truly possible to do early or delayed, and the patient is in an age group where you can truly do an early or delayed, for example, somebody 70, you cannot do a delayed, then you could go by patient choice, provided they don't have high-risk disease and all of that. So multiple factors come in. The funny thing is that this, like the IFM trial, the transplanters look at this and say, we want transplant one. And the people who are not in favor of transplant look at the overall survival and say, oh, enough, no more transplant. But the truth is not in either extreme. It's right in the middle.
Right. But I think from a patient perspective, having that longer first remission, as you were emphasizing, María, is significant and quite important. Disease-free intervals are very, very important. So anyway, a lot of discussion about this particular study and its results. Moving on to the topic of this session, obviously we have the Griffin trial, which Vincent showed, which shows DARA VRD with improved PFS versus RD, and then we had some discussion. I don't know, there's an echo happening now, but of quadruplets, which was from Durie, and he looked at it from transplant eligible patients. And his conclusion was that the addition of anti-CD38 is, if feasible, is really an excellent option. And then he looked at it for transplant not eligible, and then he was really looking here at DRD, DARA-RD as the standard of care versus VRD, and in some discussion with Vincent on this in terms of what would be the ideal treatment for patients who are not transplant eligible. And so do we need to, he raised the question, DRD is actually remarkably good for patients not eligible for transplant. So do we really need to improve on that, especially for elderly or frail patients? And so I think that there are different issues to consider for the transplant patients or the transplant ineligible patients. But Vincent, where do you think we are in terms of quadruplets as standard of care?
So I think Thierry and I agreed, for the transplant ineligible patients, it's really not a quadruplet question at this point. It's either right. VRD or DARA-RD or some other triplet, depending on what's available, what's cost effective for that particular setting. Both right. are great regimens. You have done one of the trials. He has done one of the trials. For the transplant eligible patients, some might feel that the quadruplet has already shown better PFS, and therefore it is the standard for all patients. Some might, like me, might feel like it's not yet the standard because we haven't shown an overall survival benefit, and I'd like to see some more data from the Griffin or some other trial on the overall survival. I'm comfortable giving the quadruplet to high-risk patients. Will I be willing to give it to a standard risk low young patient? At this point, we are doing a randomized trial to see whether everyone needs a quadruplet, or if people are already MRD negative, maybe they can do with a triplet alone. Right. So I'm a little bit more circumspect about the transplant eligible standard risk patient for whom some patients, a triplet might get them the MRD negative status, and you can add the fourth drug when you need to. It's ultimately a question of cost and toxicity concerns. Otherwise, you could do 5 drugs and get better PFS too.
Right. I know these are complicated things, but certainly cost and availability are big issues. And certainly for the elderly, a triplet does a pretty good job. Okay, so we're going to have to move ahead here just to touch on some of the really important things. So a key question that came up, people are excited about using CAR T-cell therapy earlier, even in high-risk smoldering, but Tom Martin highlighted the possibility of integrating CAR T-cell therapy, which are the kind of the maroon blocks in these 2 diagrams here with CARTITUDE-5 and CARTITUDE-6 in newly diagnosed myeloma, transplant eligible or non-transplant eligible. And so basically, the idea is to see if CAR T could end up maybe even substitute for autologous stem cell transplant and maybe give us not just improved PFS, but maybe improved overall survival. And so he was proposing a new paradigm where for the transplant eligible, we would slot in CAR T-cell therapy, and for the transplant ineligible, and then consider maintenance or no maintenance. So really the question to both of you is, do you really see that this is going to be the way forward, that we should expect that CAR T will represent an improvement in this early setting? What do you anticipate these trials to show?
So we will see. We have to wait for the transplant ineligible.
Yes.
Yeah, for the transplant ineligible, I think that this CARTITUDE-5 clinical trial is restricted to fit patients because, well, very elderly patients definitely are not eligible for VRD followed by cilta-cel. And concerning the CARTITUDE-6, definitely some interesting trial, and we've just been discussing about early transplant versus late transplant, and now we are going to remove transplant and we are going to replace it by cilta-cel. Well, we have to see the benefit in overall survival because transplant is cheap and affordable basically in whatever country and in whatever hospital. And this is not going to be the situation for CAR T-cell. So the magnitude of the benefit has to be very, very evident in order cilta-cel to replace the autologous stem cell transplantation. This is my point, and we will see, because in principle, the trial is planned to win, but we have to wait.
Yeah, and I don't think PFS alone for this trial would be enough, even though it's written as a endpoint, primary endpoint. You know, they can pick any primary endpoint they feel like, but that doesn't make it right. I think, like Marie said, given the cost and the expense of this treatment at this point, compared to, say, 10 years from now, where it might be cheaper, you want to use this only if there is a huge overall survival advantage to doing it instead of transplant at this point.
Absolutely.
And especially, audience has to know that we need a long-term follow-up in terms of safety profile for CAR Ts because we are starting. So definitely we need time in order to incorporate this in the first line of therapy, of course.
Yeah, so absolutely. I mean, we need to look at efficacy, but also toxicity, costs, availability, a lot of factors that would play out and how this could or maybe not move forward. Yeah.
But I think, Brian, the main thing that Marie said is, like, we are telling ahead of time now that to adjudicate this trial, Marie said two things: overall survival improvement of a sufficient magnitude.
Right.
It's really important not to just dilute that, 5-10 years from now or 5 years from now when the trial reads out and everybody thinks that this is. So because of the long-term effects, we have no idea.
Absolutely. All right. So what we're going to have to do now is just to skip forward over some of these points, and I'll just touch on them. The main thing that Paul Richardson emphasized is that the BCMA-targeted agents do represent a fourth treatment pillar, which we were just talking about. And so he did emphasize that. He also touched upon some of the other newer therapies that we should be aware of. In early relapse, Philippe gave quite a few suggestions of combinations to think about, either involving proteasome inhibitors or pomalidomide if patients would be getting a quad in the frontline setting. And so it is quite tricky and interesting to look at what would be the backup options, especially related to traditional therapy. And he looked at it both in the frontline and transplant eligible, transplant ineligible. Then Thanos Demopoulos discussed whether will we continue to use IMiDs. There is this discussion right now because of cell mods and immune therapies. Maybe we will not be so reliant on IMiDs anymore. Well, he showed a whole list of ESMO and EHA recommendations, which do, in fact, continue to include, for example, pomalidomide in a backup setting, although it is possible to use daratumumab and a proteasome inhibitor for example, as was done in the Candor study. But basically, the bottom line is that IMiDs will continue to be used because we're familiar with them. And the fourth bullet on this slide here, anti-BCMA-based therapies like belantamab combined with pomalidomide, for example, turns out to be rather a good combination. And so I think that everyone is feeling that IMiDs will continue to be around for a long time, and maybe combining IMiDs with some of the newer immune therapies could end up being the way to go. Saad talked about the best positioning for bispecifics. One key thing about the bispecifics that he touched upon, bispecifics are off the shelf, they're available, this is great. However, fixed duration would make them much more accessible broadly, and we really do need to look at that more strongly. In the later relapse, Ken Anderson from the Dana-Farber gave a really elegant discussion about what he looks for in the future. And maybe you guys could comment on this in red, prediction for the future, long-term disease-free survival and potential cure will be achieved with a combination of targeted and immune therapies and restore host memory anti-myeloma immunity. So he was really emphasizing the importance of the immune system in achieving long-term disease-free status. So Mary V, how did you react to that? What do you think about this?
I completely agree. You were discussing previously about the role of IMiDs, and definitely I think that IMiDs are well an ideal complement to all immune therapies that are coming to the treatment of patients with multiple myeloma, and we have to combine these elements with the minimal residual disease negative sustained over time, and definitely cure means disease-free but also treatment-free. And so my goal, and I think that what we have to do is to finalize with this sentence that reads in all manuscripts at the beginning: myeloma remains an incurable disease. We have to challenge this dogma of incurability of myeloma, and I agree with this prediction.
Yeah. I think we certainly need to pay much more attention to that restoring of the host immunity, that's for sure. Yeah. And so we could just touch on this. We had a very nice discussion about entry criteria for trials, and clearly this is an area where we need to push harder so that novel trials can be more broadly available, and this will certainly be an IMWG initiative. And then we move forward into our working group reports, which I just want to touch on. For smoldering myeloma, I think that, Mary V, I think that we've touched on the major issues, which are, what will be the best therapy. It's going to take time for us to get the best criteria for high-risk smoldering, and then sort out what would be the best therapy. I think that in the bone disease, maybe Vincent, you could talk about this. I think the main thing that came out of the bone disease committee this year was that they are planning to have a virtual imaging database, which seemed very, very good. So to collect images from patients for joint analysis. So I don't know if that caught your attention, Vincent.
Yes, they are planning that, and de-identified images. If institutions provide IRB approval, they want to collect it and then be able to assess both, impact of MRD, impact of bone imaging negativity, along with the MRD negativity on outcomes and things like that.
Yeah, so this was a very important new thing, which is one of the things that we're always looking for at our summit. And then Tom, Martin, and Yilin from the Mayo Clinic, they talked about the two things which we've discussed a little bit, which is the immune therapy database, where Tom and Yilin have started a new database where they're collecting outcomes for patients who are on immune therapy. And so this is a very, very important new initiative. And linked with that is the establishment of a virtual tissue bank, which will be a very, very helpful companion piece. And then a last comment that we can make: in the mass spectrometry committee, there was a proposal to evaluate low spikes which occur on mass spectrometry. The key point about mass spectrometry is that it's more sensitive, and so that you can pick up very, very small spikes. What has emerged is that at that very, very low level, some patients can have low spikes, particularly IgM spikes, which may be transient. These are spikes which maybe are not persistent and maybe do not turn into MGUS and move forward in a significant way. And so, Mary B., what was your reaction to the information about the low spikes that have showed up on mass spectrometry?
This is extremely important because these low spikes can represent the monoclonal antibodies we use as a therapeutic agents. Sometimes the oligoclonal bands we see as part of the immune reconstitution, maybe they can be evaluated also by mass spec. And I think that this is the great advantage of this sensitive technique, that we are going to be able to identify the different spikes and to see what is specifically the spike corresponding to the disease, and to put in context what is the rest of the spikes.
Right, absolutely, absolutely. The high level of sensitivity is crucial to track known spikes. So if a patient has a known spike and you know the mass of that spike, you can track it to a very, very low level. But if you're screening a patient and you find a low spike, it might be one of these lower spikes which may or may not persist. So this is a new initiative to try to figure that out. Yeah. So I'm sorry to rush towards the end here, but the big impact for our audience is that I've really just scratched the surface of these many discussions that were happening at our IMWG annual summit this year, and many more interesting details were presented and discussed, and it was, I would say, one of our most fruitful, if not the most fruitful summit that we've had. And so final comments, Vincent, were you happy with the outcomes of our summit this year?
Yes, Brian, I was. It was a great summit. I just also want to point out that I've been answering trying to answer all the audience questions on the chat. So people who are listening on the chat, I've been trying to go one by one and answer all the questions.
Yeah, thank you so much for that, Vincent. And we've been tracking them as well, and just not enough time today, but we will follow up. Thank you for doing that initial follow-up, and we'll reach out to people who have important questions and get back with you. So apologies for that. Any final words from you, Mary V?
No, it has been a great pleasure to participate first in the summit and now in this webinar dedicated to the patients, and hope to see you in the near future.
Absolutely. It is great where we will indeed most likely see you in the near future, which is great. Yeah.
Absolutely.
So I hope that this was worthwhile for our audience today. I really tried to identify what were some of the high points and discussion points, and hopefully that was fruitful for all of you. So thanks to Mary V, thanks to Vincent, and I hope everyone has a good rest of the day. So thank you.